Our next speaker is Dr. Genevieve Melton-Meaux from the University of Minnesota, and she is also part of the faculty at the Institute for Health Informatics, as well as the Chief Data and Health Informatics Officer at the Fairview Healthcare System. And she'll be talking about the diagnosis and management of persistent and recurrent anal cancer after chemoradiation.
Hi, everyone. Thank you. Thank you, Alice, for the introduction. I have no disclosures. And so anal cancer, we all know about it. It's a relatively rare cancer, accounting for only 0.5% of all cancers, but really has a very interesting epidemiology with increasing rates every year by over 2%, especially in women. It's important to really note, though, that we expect probably over the next decade or so that the epidemiology is going to change quite a bit with vaccination with HPV. And so hopefully we'll see much lower rates overall. The incidence of anal cancer is very much linked to HPV, higher in women, those that do have HPV infection, and also increased cigarette smoking, anoreceptive intercourse, and HIV infection. So in many ways, although we talk about it as a GI cancer as colon and rectal surgeons, it's really more similar to genital cancers. There is quite a lot of evidence with anal cancer, really starting with our understanding with the NIGRO protocol in the 1970s, making chemoradiotherapy really the mainstay. And there are a handful of randomized controlled trials, which I'll just go over briefly. Some of them showing the superiority of having radiation with chemotherapy, and then learning that adding 2,5-FU mitomycin improves survival. And then also learning that induction therapy had better outcomes. And finally, really showing the equivalence between cisplatin and mitomycin. This final trial, the ACT-2 trial, also looked at maintenance chemotherapy and really found no benefit from that. So now taking these and talking about the problem at hand, what about persistent or recurrent disease? And really, I would say there's a couple messages here. Overall, you're going to have to take what I talk about with a grain of salt, because at best we have moderate evidence for what to do around persistent or recurrent disease. And this is because we really don't have prospective trials on surveillance. I'm going to talk a little bit about some of the post hoc data that comes from the prospective trials. But really, because of this, and also when you look at different institutions' series that they report, there's a variability in how patients are followed, as well as how they've been treated. And then really, when you look at the expert guidelines as well, they're helpful, but again, there's a bit of variability. So do take this all with a grain of salt. So what about surveillance? Again, no prospective trials. I think really when we talk about that, it really comes down to the questions of when, where, how, why. So when, starting at least at 8 weeks after therapy completion, what? Now, I wrote these parts down about what you do, but if there's one thing I would encourage everyone to do is really document this well. Your digital rectal examination, anoscopy. If it's a difficult cancer to see, you may have to do it under anesthesia, and be sure to palpate the lymph nodes in the groins. Today, many of you have the opportunity to take pictures, put this in the electronic health record. It really does help. What about biopsy? So if it is suspicious in the area that there's persistent or progressive disease, of course, do biopsy. There's a lot of controversy of whether or not to biopsy if the physical exam is normal. I do not. There are some that have done this routinely, and this has been a teaching that I was taught in fellowship, but I believe most people today do not biopsy if the physical examination remains negative. So how often? There are a variety of recommendations around this in particular, but most say up to 5 years, at least every 3 months for the first 2 years. Many will be seeing these patients every 2 months for the first 2 years. And then every quarter, some people go to every 6 months after the first 2 years, understanding that the first 2 years are the most common time point that recurrence will happen. And then imaging. Imaging is done at least annually for the first 3 years. Our oncologists will do it every year, and in fact, will also do this with a PET CT, and that's becoming more and more the standard of care for imaging. So, persistent disease. Okay, so this is really the analogy overall. We want to be aggressive, but if anything, sit on your hands, take your time with persistent disease. So if disease does progress despite therapy, so that's why measuring very closely and monitoring is really important. The recommendation is a salvage APR. However, if the disease persists, the question is really how long do you wait? And if it does persist, how does this affect the prognosis? So those are really the questions. So again, the Act II trial was one of those randomized control trials that I showed you before. This was done in the UK over a large number of centers, quite a few patients. Again, comparing mitomycin and cisplatin, they were equivalent. Also comparing whether or not doing maintenance chemotherapy made a difference. It did not. And this is a post hoc analysis of what those patients, as they were followed, what they saw. So a couple things. They had a standardized way that they were assessing patients at 11, 18, and 26 weeks. And you can see that the complete clinical response was 50% 11 weeks and went all the way up to almost 80% at 26 weeks, so half a year. And then you can see that if the patient did achieve a complete response, that the survival rate was the same. So if you do get a response over that period of time, a complete clinical response, it doesn't, even if it's later, it does not affect your overall survival rate. But on the flip side, if you do not achieve that complete response, it does affect your survival negatively. So I think the other message here is when you do see these patients post-op, you do need to reassure them quite a bit if things aren't completely regressed at 11 weeks and just continue to follow them. The other way to kind of look at this, if you look at, about half, again, had a complete response at 11 weeks. The remaining, if you took that other half, 2/3 had a complete response after that. So it's just to say, again, do reassure them because still, even if they haven't achieved that at that point, more will achieve it following that. Okay, so what about the role of surgery? So a couple questions, really understanding, what do these patients go through, how often is diversion required, and then really who's going to require a radical resection really because of recurrent disease. So again, this is the Act II trial, again, a post hoc analysis, looking at different types of surgery that were done, either a pretreatment colostomy, because of the toxicity of treatment, needing to get a colostomy. And then they call this a tumor-related colostomy, but in these cases, it was a radical resection. Okay, so as you can see, again, the 900 patients, at baseline, about 100 had to get a colostomy. And then over time, a combination of about 50 patients ended up getting reversed over time, but the remaining did not. And then if you look, about 100 ended up getting a resection. And this is pretty consistent with the literature, really that about 15% or so of patients are going to need to get a salvage APR of some sort. And this is just a different way of looking at it, that over time, the need for salvage APR. So this is the largest. So the previous one, the post-hoc analysis of the Act 2 trial was overall the need for surgery. And this is looking at it a slightly different way. This is the largest series of patients that needed to go ahead and get an APR over time. Again, this was similarly about 15% of the overall population of patients in this group. And again, this was done for persistent tumor, and about 40%, which is higher than the literature overall, and then recurrence in about half. The cohort's a little non-pure because it also included patients that didn't get standard of care treatment with radiation therapy. But this is informative in several ways. The first is that surgery, when it's done for salvage reasons, often is delayed quite a bit, but the median was about a year. And that in many cases, especially for the patients that had persistent disease, there were other procedures associated with it. The other really important part to note is that about half of the patients ended up getting a flap, again for the larger defects in particular. They included omentectomy and other procedures to help cover with tissue, but again, the flap being the more viable, larger piece of tissue. And again, these are big procedures as a whole. This was in France, so maybe there's some differences as far as length of stay, but quite long length of stay. And really, I think the final message overall are that the perineal wounds are difficult to heal. So when you look at the literature, overall, whether or not you look at patients that get a flap or those that do not, the rates of having issues with the perineal wound are quite high, 30 to 40% overall in the literature. It is not really a fair comparison because it's a very biased sample. It's not that we randomize patients to get a flap or not. The ones that do not get a flap have a smaller defect. But it's just to say, overall, there are high complications with the perineal wound. It's an irradiated area. So those patients that do have larger defects, in this case, be very proactive and do consider doing a flap. Have your plastic surgery partner there to help you with that. So the message here is be proactive. So really in closing, if there's anything to keep you with, it's be very careful as you monitor these patients and really think about twiddling your thumbs or being very proactive when it is time to intervene. Thank you. I give them the spiel. I try to tell them the statistics, but the reality is these are patients that are anxious for a very good reason for their disease, but it's really just saying we know that the radiation continues to work, et cetera. Yeah. Well, I think it depends on how much they received, but unfortunately, if it is perianal and it does not involve the sphincters, you may be able to resect and not have to do a radical resection, but if it does involve the sphincters, you really have minimal options at that point, except to resect radically. That's a great question. So Wolfgang asked how long we wait typically. I usually wait about 2 months, but they often just show up because they want to be seen. But I do try to reassure them and try to get out to that 2 months if at all possible. So Anne asked if we use local imaging. I do. I tend to use MRI up front. And then I like to see that it has regressed. I don't know if that really is standard of care. It also depends on where it's at. That would be something that's in the anal canal or really approaching that. Obviously, if it's along the anal margin or outside of that, I don't in those cases. So Alice asked if we biopsy afterwards if they've had treatment. I do not if it looks like a complete response. I only do if it appears to be persistent disease or coming back. And I do wait I wait at least 4 months before I start biopsying. But if it does seem like it's becoming larger in size, then I will. Yeah. All right. Thank you very much.